Hello and welcome to the next episode of the Complete Physio podcast. My name's Chris Myers and I'm here with Mr. Luke Jones, and we're going to be talking about ACL injuries. Now, we have done an ACL injury podcast before, but we are going to specifically look at whether or not people should have ACL surgery, and if they do opt for surgery, what is the best option for surgery, i.e. what graft should they use? So I think this is going to be very useful if unfortunately you're sitting at home and you've just injured your ACL and you need to make a decision about what to do. So first of all, Luke, many thanks for coming.
Sure.
So just tell us, what is an ACL injury and how do you know when you've done it?
So the ACL is one of the most important ligaments in the knee. It sits in the central part of your knee and crosses over with your posterior cruciate ligament. It runs from the front central part of your shin bone upwards and backwards and into the outside part of the notch of your thigh bone. And what it does is it controls rotational movements and allows your body to know where the knee is in space. So as we discussed before, it's a bit like a seatbelt. It catches you as you come forward and stops your knee from pivoting. And usually when people tear their ACL, in about 50% of the time, slightly higher in females, it's a non-contact injury. 50% of the time it's a contact injury. Someone kicks you in the leg and you tear your ACL. But in those times where it's not a contact injury, it tends to be during deceleration or change of direction movements or landing movements where the forces through the knee are really high and it goes beyond the elastic limit of the ligament and you feel a pop in your knee gives way. The patient, the athlete then tends to tell me they fell to the ground and they knew immediately they'd done something.
Yeah.
Because of the blood supply to the ACL, there tends to be a large amount of bleeding into the knee. And so very often people say, by the time I got to the sideline, my knee was large and swollen. And then typically patients will have a feeling of instability or giving way in the knee. And that might be on day-to-day activities, stepping down off the curb or coming down the stairs. Or they might have instability on higher level activities such as running and changing direction.
Yeah. Okay, cool. And how will you know? Like, do you have to have an MRI scan? How do you know for sure if you've done your ACL?
Yeah, with all parts of orthopedic diagnosis and clinicians who see these sorts of injuries, it's a combination of the story the patient tells you, the examination findings, and then the imaging. And so that's the typical story. The examination findings are a swollen knee. Often there's a restricted range of movement on the knee. The knee for specific tests where you bring the shin bone forward on the thigh bone, that movement can be greater than on the other side. It's always very important to check both sides. And often you can do a sophisticated test where you try and twist the knee. And often the patient won't let you do that, or you might be able to what we call pivot the knee itself. And then you're right, the next step would be then to organise some imaging. And as always, what we would do first is an X-ray to make sure we've not seen a fracture, because a fracture or a break, these are synonyms, that can often present with similar findings. And then an MRI scan. And MRI scans, as you know, look at the soft tissues inside the knee. So although you can see the bones, they're specifically for things like the meniscus and the ligaments and things along those lines.
Okay, cool. So let's say somebody's sitting at home. Unfortunately, they've had the news that they've ruptured their ACL. So you can do a partial tear, can't you, of the ACL? But we're talking about a complete rupture here.
Yeah.
What are the options for people from here in terms of the ACL? Do they have to have an operation?
Yeah, so I think the first thing to say to that answer, Chris, and so obviously, as you know, it's a difficult one to give a black and white answer to, is that the ACL often is part of a spectrum of injuries inside the knee, right? So depending on the severity of your injury, you might have damage to the cartilage surfaces, to the meniscus, to other ligaments. So for the purposes of this conversation, you and I are just going to talk about isolated ACL injuries. But if people are sitting at home, they're going to have there's going to be a big spectrum of injury. And under that circumstance, that's why it's important that you go and see somebody to have that personalised approach to your care. But we know from some very, very good studies that have been around for at least 15 years that if you randomize people to having an operation early or having rehabilitation, right, and then having an operation if your knee is still unstable during the rehabilitation. So you've got three groups of people now. People that have an early operation, people that have rehabilitation and don't need an operation, and people that have rehabilitation and do need an operation. Only about half of those people that are allocated to rehabilitation will need to go on to an operation.
Okay.
And what that suggests to us is that 50% of people can cope and by cope we mean go back to the level of sporting activity they want to do, about 50% of people, non-elite athletes, 25 to 45, can go back to the entire function they want to do without an operation.
Okay, so that's really interesting. So the answer to the question is part of the answer is you don't have to have an ACL reconstruction.
Yes, and you don't have to have an ACL reconstruction to get back to the level of sport that you want to do.
So you can cope. People can cope, can't they?
And this isn't about we're retiring you and you now are only going to play chess.
No.
This is about going back to what you want to do. What you want to do.
Sure.
Yeah.
And I assume in the research that was a spectrum of different sports, from skiing to rugby to football.
That's right.
Yeah. So let's say that we've decided not to have an operation. So I think there's lots. I'm 44. If I ruptured my ACL today, I would personally, because I go to the gym, but I'm not doing a lot of cutting stuff, I personally would probably try and manage it conservatively unless I had these other associated injuries like the meniscus and that sort of thing.
Yes.
But who therefore should have an operation? Right. What are the signs and symptoms? Right. And when you're with your patients, what are you specifically asking to find out or ascertain whether or not an operation would be the right thing to do?
So I suppose the first question is, why would we do an operation in the first place? And there's two reasons. One is to return you to your normal level of function. And the second reason is that we're worried about what that means for the knee in the long term. So if we want to get you back to playing pivoting sports, that's one thing. And the second thing is that if your knee is repeatedly giving way, then you're going to damage other structures in your knee. And we know that if you damage other structures in your knee, then long term that can be very bad for your joint function and joint health.
Yeah.
So what I'm interested in when people come to see me is what their level of function is and what they want it to be, and whether or not they're unstable, right?
Talk to me a bit more to a layman about what you mean by unstable, this giving way.
So the feeling of functional instability varies from person to person and depends on what their activity levels are. But instability is a feeling of not trusting the knee in some people. So from a feeling of not trusting the knee to do what you want it to do, even though it doesn't actually give way, all the way up to I change direction, my knee goes and I fall to the ground.
And I fall, yeah.
So again, that instability is a very subjective thing, and that's why the individual story is very important.
Yeah, absolutely. And it might be that walking around they don't feel unstable, but as soon as they start to do a little jog or change direction, they start to feel it.
Yeah, that's right. And then you and I have also managed patients where jogging's fine, in the gym they're fine, changing direction in training's fine, but when they come to play football and somebody nudges them in the back and they're changing direction, they'll think about it and then they're unstable. So it can be that entire spectrum.
Yeah. So at that point, you either give up the sport that you're unstable in, or you go potentially for an operation. But what we do know is if your knee just keeps giving way, you are damaging your knee, and long term you could get arthritis. So it's not a good thing, is it?
That's right. That's right. So what we're worried about is that you're going to damage the cartilage surfaces, which are the smooth surfaces covering the end of the bone. And then, of course, that's going to give you arthritis. Yeah. Or you're going to damage your meniscus. Once you've torn your meniscus, that increases your risk of getting arthritis in the long term.
So we're talking about arthritis now. So if somebody's sitting at home, they're thinking, well, I want to do an ACL reconstruction because I've been told that if I don't do it, I'm going to get more arthritis when I'm older, which you still hear sometimes. But just talk me through how you would counsel your patients around that.
Yeah, so that's not what ACLs are for. ACLs are for functional stability, to get you back to your normal level of function. And I think if anybody tells you that I'm doing your ACL to stop you getting arthritis, then they're missing out a couple of steps in that conversation. So the conversation really goes, you're unstable, so we're doing your ACL, because if you're unstable, you might damage your meniscus. And if you damage your meniscus, you might get arthritis. So A equals B equals C equals D, but A doesn't necessarily equal D. And so we've got to be really careful about people coming to clinic. They've got they've hurt their knee, their MRI shows a ruptured ACL, but they're not unstable. And suddenly we're saying we must give you a really big operation and send you off for a year's worth of rehab. That's something that we've got to be cautious about.
Yeah, absolutely. Because we, as we were saying earlier, that we know that the research shows, and correct me here if I'm wrong, but the research shows that the risk of arthritis is done at the time that you do your ACL injury. So I think it's not actually related to whether you have it reconstructed or not.
And so one of the things we've got to get used to now is thinking of the homeostasis of the knee joint. And when you have a big injury like tearing your ACL, It's not as though the ACL in the middle of a normal joint just goes like that. The whole joint is injured. There's injury to the bone, injury to the lining of the joint. We know that if you then take samples from the fluid inside the knee, it's full of inflammatory mediators. So we know that the injury itself is the risk factor for arthritis. Being unstable is a risk factor for arthritis. But also, interestingly, from some large data sets in places like Denmark, that having an ACL reconstruction is a risk factor for arthritis, right? And partly that might be because you then go back to sport and you damage your knee more, right? And so, or it might be that having an operation is another injury to the knee and creates another inflammatory environment inside your joint. So it isn't that ACL surgery is a bad thing. It isn't that not having an operation is a bad thing. It's about function. What do you need from your knee, and how are you like from a functional point of view?
Okay, cool. And there's been a recent research, I think it was last year, that showed that some ACLs heal. So the first question I would ask as a patient, if you told me you've torn your ACL, you've ruptured your ACL, I'd go, well, will it heal? Will it heal?
So the teaching around ACLs goes that they don't heal because the blood supply is in the center of the ligament, right? And you tear it, so the blood supply is disrupted. All the fluid inside the joint gets between the ends of the ligament, and so it can't possibly heal, right? But we need to think about how ACLs actually tear. And so because they're not a stick that snaps in the middle, it's actually thousands and hundreds of thousands of collagen fibrils. What actually happens is that they go like this, and they come out to their elastic ligament and go, right? Like a bit of blue tack that you stretch too much, right? So some tear like that, some are pulled off the thigh bone, and then unusually some are pulled off the shin bone. And so if you're in a scenario where you have avulsed or pulled off the ligament from the thigh bone, then there are operations we can do to stick it back down. And occasionally I'll go into somebody's knee and they'll be really close to being perfect, just not quite right. And what we'll see is that actually the ACL's healed up in the wrong position.
Right. Okay. And so it reattaches.
Yeah, that's right. Yeah. So it can do that, but that's if you've got that specific sort of tear. And so the story is a little bit more sophisticated than they do or they don't heal. But the study that you're talking about relates to that original study, so the Canon trial from 2010 in the New England Journal of Medicine. And in that one was the one where they randomized people, as we discussed, right? And what they've done is they've done a follow-up on that, and they've looked at the people that have coped without an ACL, and they've MRI'd them, and they've looked at they've had some MRIs scans that show that there is evidence of healing. And so the discussion then goes, well, what is the evidence of healing, and how many patients are there? Well, the answer is that, and you and I both know that we would agree that 50% of people don't need their ACL done, right? So 50% of functional.
And if it's not giving way and you're happy, this conversation doesn't even matter, does it?
It doesn't matter, right? So in those patients where they coped, well, they're already copers, right? When you scan those, 16 of them had got evidence of healing. So we're talking about 16 patients, right? And then when we talk about, well, what does healing mean? Well, they've got a Likert scale, 0 to 3, so 4 points on the scale, right? And 0 is normal, 1's a bit healed, 2 is elongated and thinned, and 3 is completely absent. They said that 0, 1, or 2 was healed. Of course, you haven't got a normal ACL, of those 16 people. And then, so look, there's all bits where we can say we do or we don't like studies. And I think what we really need to say is that Martin England and Frobel and all those guys have done an unbelievable bit of work that have transformed the way we approach ACL injuries. But we aren't in a position now on the basis of 16 MRI scans where we start telling everybody that comes to clinic, your ACL is going to heal. We just need to have a sensible conversation about function. Right.
Which goes back to your first point, doesn't it? Is that if you've got a knee that's functioning okay and you're doing everything you need to do on it, fine, keep going.
Now we've got a different question. Exactly.
Okay, so let's say now that the person that you're seeing has decided that they're going to have an ACL reconstruction. There's probably, I don't know, there's probably now up to 8 different ways of doing it, isn't there? So can we just talk through the options you have to repair an ACL, particularly talking about the grafts? So you could have a quadriceps graft, a hamstring graft, a patella tendon graft, an allograft. You could have an internal brace. Like, where are we with all of this, and how does that and how do you use your knowledge of that to influence how you would repair an ACL?
So I think there's when I think about ACL injuries and how I'm going to treat them, the choice of graft is one very small part of the entire process, right? So you've got to have the right diagnosis, you've got to have the right timing in the right patient. And then you've got to get a graft, you've got to get the right graft, it's got to be the right size, you've got to put it in the right place, you've got to fix it correctly, and then you've got to rehabilitate the patient correctly. So I think that very often, and you go on forums and you see this and everyone's obsessing, oh, you had a hamstring, I had a BTB, you've made the right choice, I've made the wrong choice, right? People often get really worried about that. And in fact, it's not the most important question. No. And if we look at all the big data sets, as often with data sets, there doesn't really matter. But when I think about, if we want to talk specifically about graft choices rather than the other nuances, there's two things. You can have autograft, meaning I take the graft from you, or allograft, meaning I take the graft from somebody else.
Synthetic?
No, so under these circumstances, they would be from cadaveric donors, much in the same way people donate their hearts, their kidneys, their lungs, and things along those lines, right?
Okay.
And so autograft or allograft is the first thing. And here we're talking about reconstructions. So it's really important to get the terminology right. And I think often they get mixed up. So we have ACL repair, one topic, controversial, we're all excited about it. And ACL reconstruction, established, we know it works if done as part of the big spectrum of treatment that we're talking about. So autograft, you take it from yourself, and then allograft, it's given to you by somebody else.
Okay. Perfect. Which one should we deal with first?
So, well, if we talk about autografts, then these are ones that we would take from one part of your body, put into the knee as the new ACL graft, and then fix in the right position.
And in your hands, what do you use a majority of the time?
So I like to pick the graft that I'm going to use for the patient.
I knew you'd say that.
Okay. Well,
it's true.
Well, it's true because we talked about thinking about the patient on their individual functional basis, right?
Because some surgeons do just go, I do a hamstring graft, don't they? Or they seem to favour one, but what you're saying is that you will.
Well, I think that certainly traditionally, depending on where you did your training and how you did your training, that was the story. Right? But what we know now is that if you want to give the base treatment to patients, then you should be able to give them the choices. Now, whether I give someone an autograft and allograft, that's a different thing, because what we do know is that the allograft data, say from somebody else, the rupture rates are higher. And I think it's unusual now to give somebody under the age of 35, or probably even older realistically, an allograft. And the reason the rupture rates are higher is probably it takes longer to integrate into you. But also, I suspect, it's because you don't have what's called donor site morbidity. So if I take your hamstring out, your hamstring really hurts, and that's like a break, right? It stops you from overdoing it with the rehab. Whereas if I put a hamstring into you, you'd feel great straight away, right? So, an allograft hamstring.
I mean, I've seen a few, and they do seem to have less post-procedural pain when you do an allograft.
That's right.
But then there's that risk of re-rupture.
And that's why they're so attractive, because you don't have the donor site morbidity, so the pain from where you've taken the graft from. And I suspect that there's two reasons they rupture more highly. One is because it's not your own tissue, and so it takes longer to integrate, and so therefore you're more likely to tear it. And then secondly, because you don't have the handbrake on from the donor site morbidity pain, right? And so then when we talk about the autografts that you might take, the choice is to take them from the same leg or the other leg. Right? I prefer to take it from the same leg in the setting of an isolated ACL. If you've got a multi-ligament reconstruction, you might need to take grafts from both sides. And the reason I do that is because I don't want the patient to have two injured knees. Right? And then...
and it works generally, doesn't it? Doing that. Work. It's not like absolutely. You need to look for another option.
No, that's right.
It generally works.
No, that's right. And then your choices then consist of, broadly, some tendon from the front of the knee, so from the patella tendon running between the kneecap and the shin bone, and you take a bit of bone on either end there. Hamstring tendon, where you can take one or two tendons, and then quadricep tendon, which is taken from between the quadricep muscle and the insertion of the patella, which is the kneecap.
And give me some situations where, and I'm thinking of basketball players, like where you would avoid, say, for example, a patella tendon graft over a hamstring. Are there any situations, examples you can give us where your decision-making favours one over another?
Well, one of the nice things about a patella tendon graft, and I do a lot of patella tendon grafts, is that you are fixing bone into bone. And so you know that it's
just
6
explain
weeks.
that, Luke, in a bit more detail just for the viewers.
That's right. So when you do an ACL reconstruction, what you do is you drill a hole in the shin bone and a hole in the thigh bone. So you've got bone tunnels. And then you take a bit of the kneecap, the tendon between the kneecap and the shin bone, and a bit of the shin
So you got
bone.
a bit of bone, then you've got this nice
Tendon.
graft, then you've got a bit of bone at the end.
Yeah.
Yeah.
And that means that you're then putting these bone plugs into the bone tunnels and you're fixing it. And so we know at 6 weeks they're going to be healed in.
And bones heal beautifully, don't they?
Lovely, without a scar, right?
Yeah, yeah.
So you get this sort of bone-to-bone healing at 6 weeks, and so you can be slightly more aggressive with the rehab and things along those lines.
Yeah.
And the graft is stiffer, etc., etc. But the problem is that if you're a very small patient, then you tend to have a narrower tendon.
Right.
Your patella is likely to be smaller, and therefore taking a bit of bone off
Right,
the top is an increased risk of damage to the patella in the first place. And if you do sports or you have a job that involves kneeling down, so in America, if you're a wrestler, or in the UK, if you're a rugby player, you spend time on your knees, or, like a lot of patients that come to see me on my NHS practice, they work as plumbers or things along those lines. They're kneeling down on that scar and they really don't like it. But if you do sports that involve a lot of deceleration, taking the hamstring then can be difficult because the hamstring is so important with your deceleration movements.
Yes, absolutely.
Right?
Yeah.
And for jumping athletes, it can be, we probably don't want to take either of those. You can take the quadriceps, but then we know that getting that last bit of terminal quadricep firing in the rehabilitation
can be a little bit,
harder.
because from a physio point of view, I think there's pros and cons of both.
As always.
With the patella tendon, just from experience, there seems to be a slightly higher percentage that end up, or there is a percentage that end up getting a bit of anterior knee pain.
For sure. Yeah.
The hamstrings, obviously, occasionally they do tear the graft site. Quads tendon, I haven't had that much personal experience of.
Yeah.
But it seems to vary. I think the good news is generally they both do really well in the hands of a good surgeon.
Well, I think that's right, because as we were saying before, in the right patient, at the right time, with the right tunnels, in the right place, fixed properly, which graft, and then the proper rehab. It's just not it's not the be all and end all which graft you have. I think one of the things we've seen recently with ACL reconstruction is this idea of taking just now a single hamstring, which is what I do often in smaller female athletes because they have got smaller tendons at the front of their knee. Yeah. One of the important things with the graft is the size of the graft. Yeah. And you might imagine
and
that
the bundles. Do you want to talk us through that, where we are with that?
Well, the bundles bit we talk about, but
seems to be like the bundles. Yeah, that's the more bundles, the better.
Yeah, that's
I'm not
right.
Sure
that's right. So I think the main thing is the thickness of the graft, and we know that if you've got a graft that's less than 8 millimeters in diameter, then your rupture rate goes up. And one of the nice things now is that with different bits of kit that we've got, you can actually take a single hamstring and quadruple it. So you've got a 4-stranded graft, and that means it's much thicker, and that's really.
But I suppose that means you are taking a fair amount of hamstring.
Yeah, so you take the entire length of that semi-tendinosis tendon, and that regenerates, by the way. So there's some evidence that regenerates, and people do very well from it. And the function of the hamstring, if they do their rehabilitation.
So I'm just thinking, say you had a footballer. I actually saw a footballer not that long ago who had problems, not one of yours, following an ACL reconstruction, and he kept tearing his graft site. Yeah. Now I've actually only seen that a few times. I've been 25 years in, but he's actually really struggling with it. Turns out he did have a bit of a history of hamstring injuries. Yeah, that's interesting. In hindsight, would that be something that might actually dictate maybe going away from the hamstring as a graft?
Yeah, that's absolutely right. And I think this comes back to what we were saying before about the treatments decided by the whole team.
Yeah.
Right? Yeah. And the patient comes to see me for 30 minutes. But they've been seeing you for 5 years, and for their conditioning work and all that sort of stuff. And so the communication between you and I is so important about making that decision together for the patient, right?
So I think the thing when it comes to grafts, and I would certainly say this from experience, and I think what you're saying, it needs to be bespoke to the person.
That's right.
It's one of many things that can contribute to a good outcome, but it's certainly not the thing.
No.
And actually, from a physio point of view, you do slightly change what you do depending on where they've had the graft. I'm very cautious with my patella tendons not to overload, that knee initially. I'm going to talk to you now. What I'm really interested in is re-rupture rates.
Okay.
So is there any difference re-rupture wise on a quads versus a hams versus a patella tendon?
No,
I thought that was the case, but I just wanted to check.
No, I suspect that the predominant issue is around the size of the graft, and where you place it, and whether you rehab it.
Yeah. And do you think, from your experience, a quadriceps, a hamstring, or a patella tendon? I suppose I'm probably in a good position to answer it as well. Do you find that because people just want to get back to sport quickly, and we'll come on to that actually in a minute. But do you find that there's any difference between that in terms of outcomes? Obviously, there's no difference on re-rupture, but outcomes or return to sport or anything around that?
No, I haven't found that at all.
And I think the research supports that, doesn't it?
Yeah, that's right. So again, I think it would come back to the fact that if you've got to think carefully about that individual patient and how you're going to get the biggest graft you can get for them.
Yeah.
Right. The big thing that I see when I'm doing revisions is that the graft that isn't big enough has been put in, and that the graft is put in the wrong position.
I hear this a lot about the positions of the tunnel. Can you go into that in a layman's sense, what you mean by that, and what are people doing wrong? Well, or suboptimally is probably
that's right. So the bone tunnels where you're going to plug the graft into really decide how the ACL functions inside the knee, because the ACL, the natural ACL, has got direct and indirect attachment. So it doesn't attach like a single point on it attaches like a hand. People talk about a duck's foot, so that these fibers spread out,
bigger surface area.
Yeah, that's right. And so then you as the knee flexes and extends, different parts of the ACL are under tension in different positions. But of course, we can't put a duck's foot back down. No. So the structure that we put in has to go into where the direct fibers attach. And as the understanding around ACL anatomy has evolved really over the last 15, 20 years, more understanding about where you need to put the tunnel, particularly on the femoral side, has changed.
Yeah.
And as a result, the kit that we use to make the drill holes has changed, and the techniques we use to drill the tunnels has changed. And so, there was times earlier on in my training where the ACLs were being put in a way that we wouldn't dream of doing now. This sort of transtibial ACL drilling and all that sort of stuff that you'll remember. That I just don't see anyone do. Well, right, and I saw it early in my training as well. Yeah, that's right. So I think that's changed dramatically, and that's probably one of the big things that's changed.
How do you find the right angle direction? Are we onto robots with that, or is it sort of just experience?
So there are various anatomical markers that you look for during the operation, right? And you can see often where the ACL is pulled off from, you can see that. And there are various bony landmarks that we can look for during the operation. You've just got to be really careful about orientating yourself, because one of the things about keyhole surgery is that you're looking into a very tight space, and it can be easy in inexperienced surgeons to get disorientated. And that's what it comes down to about going to see somebody who does loads of them, right?
Yeah, it's like anything, isn't it? It's like anything. Exactly that. So two things slightly, I suppose they're slightly cool at the moment, and certainly patients are coming to me asking, well, what do you think about this, Chris? And I say, go and speak to Luke. But so internal bracing and repairing of ACLs. Do you want to just talk us through both of those?
Yeah, so again, this is the difference between a reconstruction and a repair. And this has evolved around understanding how ACLs are injured. And there's definitely some evolving evidence, particularly in children, that in patients who have got pull-off injuries, so they pulled the ACL off their thigh bone, you can put it back on and repair it. The evidence of the long-term outcomes isn't quite there yet, Chris, right? And so
would you call that a primary repair?
That would be a repair.
Which has to be done within the first week, 2 weeks?
Right. So it's got to be done in the early stages. So you can't turn up 6 weeks down the line and say, and one of the things about when we see people in the NHS is that by the time they work their way through the system, that can be a little bit difficult. And so there's some evidence around that, but we've got to think about how the ACL fails, right? It stretches, it gets to its elastic limit, and then it fails. So putting back a floppy ACL isn't going to help, right?
That's a good analogy.
Right? So we've got to make sure that we're being really careful about that. Just plugging it back on, but it's not functional, is no good, right? We feel triumphantly like we've done a great job as a surgeon, but that isn't necessarily
You're going to end up with potential laxity, aren't you?
That's right. And so, and don't forget, it might be that sometimes we see people doing repairs and they're getting good results, but the patient they're doing it on hasn't had a trial of conservative management. Because by definition, you have to do it early. And so then you say, well, look, 50% of my ACL repairs do brilliantly. You're like, well, the 50% of people who don't have an operation do brilliantly, right?
And
so
the numbers in the UK for repairs in adolescents, is it still quite low?
This is still quite low. And part of that relates to the awareness around it. Part of that relates to the time of passing through surgery. I've got a repair coming up this week, right? So this is somebody that's done it in the last week. right? Who is a high level? No. So this is he's not an adolescent, but he's under the age of 20. So this is a young sportsman with ambitions for sport, right? And all those sorts of things.
So I'm really interested in that, Luke. So how did that decision-making process come that this is...
So this is an acute avulsion from the wall,
so you're going to put the bone...
It's acute, just put it back on, repair it back on, and then repair back down.
And the other term that people read about is this internal brace, which I think is what Arthrex, obviously a very large company, have termed it. Can you give us an idea of where that would be used? And I don't know if you do it or it's something you're looking at.
So internal brace is a brand name, right? It's a trademark brand name, and it's a piece of tape. Really, right?
Sellotape.
Yeah, that's right. A bit of
physio tape.
Yeah, right. So what it is, and you put it alongside the graft.
Yeah.
And it acts as like a belt and braces, right? So that if you have a little slip, the idea is that it will catch and stop the graft stretching out while it heals.
But it's bringing the two ends together.
No. So hold on. So there's a bit where you can use the internal brace during a reconstruction. So you might pass the hamstring through, right? And then put an internal brace next to it to sort of brace it while it heals. Okay.
So that seems like trying to find a solution for a problem that's not really there.
Well, I think it depends on why you think people fail. And people fail because either their graft slips or their graft ruptures. And so the idea is that after 6 weeks, if you're overdoing it and you have a turn or something like that, right? So it's the idea that it might protect you under those circumstances. Right? This isn't a dramatic thing to be doing to somebody at the time of the operation, right? So I think people are doing it
as in you're putting a bit of sellotape along,
and you're just adding it on, right?
Okay,
so
fine,
I think under those circumstances, people are doing it because they're worried about their patients and they want to give them every chance.
Yeah, sure.
And then the other time you might do it as an internal brace is alongside your repair. So again, you repair it up onto the wall.
Okay.
And then you put the brace alongside it, and you pass the brace through a tunnel and fix it.
Okay, so it's not changing everything at all. It's not like a brand new thing, is it? No. Okay, fine. It doesn't sound as exciting as I thought, Luke.
Sorry.
Okay, last thing we're going to talk about seems to have got quite popular. Something called a lateral tenodesis.
Yeah.
So this is something that my understanding is, well, it seems to be that it seems to happen quite a lot, but this is something else you can now do alongside an ACL reconstruction. So as well as doing the graft, you also do a lateral tenodesis. Can you talk us, and I have had patients come in saying, well, I'm going to go with this surgeon because he's going to do a lateral tenodesis. And I'm like, okay, fine. But, do you want to talk us through the history of why this is happening, seems to be happening more and more, and what the thought process is around it?
Yeah, so historically, when people did ACLs before there was all the advances in keyhole surgery, what you would do is you would take a bit of tendon from the side of the knee and wrap it around the outside of the knee.
Yeah.
To try and stabilize it as a sort of a secondary way of stabilizing it because you couldn't do an ACL reconstruction.
Right.
And there's been an increased understanding of the anatomy of the lateral part of the knee and the anterolateral ligament. You will have heard about this and all that sort of stuff that could be injured during pivoting movements and during ACL ruptures. And there's been an increased interest really in the last maybe 5, maybe 10 years about performing an additional extra articular, so outside the joint, lateral stabilization procedure, whether it's a lateral tenodesis or another term, right? And there's lots of different ways of doing it.
Right.
But there are lots of different companies that make different ways of doing it and all that sort of stuff. But essentially what you're doing is you're adding a procedure to the side of the knee that acts as a secondary stabilizer alongside your ACL. And there's a very good study called the Stability Study that comes out from a Canadian group where they applied lateral tenodesis in a controlled environment to those who are particularly at risk. And what it shows is in females under the age of 25 who are hyperextenders, that it dramatically reduced the rupture rate.
It was quite dramatic. I remember seeing a presentation.
Yeah, I think it was a real game changer, right?
Yeah,
It's one of those few studies that really change people's practice. Yeah,
and it's being used in the subgroup that traditionally have a higher re-rupture rate.
Well, right. So now I would do it. I'm doing it increasingly.
That was my next question, yeah.
And so definitely if you're a revision,
you
get it. And definitely if you're a top-end sports guy, you get it. Because that guy won't even consider having a failure, right? He gets it.
Yeah.
And then if you are a hyperextender, and if you're young, right, under those circumstances.
Okay. And from an incision point of view, is it an extra, you're opening them up a bit more to do that?
Yeah, that's right. So on the side of the knee, really over the, really there's about a 10 centimetre incision over the lateral, so the outside part of the knee.
That's why I mentioned it, because it is, I had a patient that didn't quite realise, again, not one of yours, Luke, who woke up and said, "Oh, I didn't realise. I thought this was keyhole."
Yeah, that's right.
Yeah.
So it's a real thing, and
Yeah.
I think if you're a hairy, large male, then you can't see it, but it can be quite prominent in other patients,
who
and
might
it can
be
be a
bothered
concern.
about
Might be bothered by
cosmetic
scars, and I think that the patient needs to be told why you're doing it, particularly if they're a high risk patient.
Yeah. Okay, that's really good. And anecdotally, on your own patients, are you finding that this is a good thing to do? And then my next question is, why don't you just do it for everybody then?
Yeah, so I think that the evidence around doing it for everybody isn't quite there yet.
Right, yeah.
And so all operations have got risks associated with them.
Yeah.
And so what you're doing is you're making an extra incision and you're in various different ways of doing it, but you're then operating around ligaments on the lateral part of the knee and you're putting additional bits of fixation material inside the bone. So there are risks associated with that.
And from a rehab point of view, I have found that they can be a little bit sorer, a little bit slower. Obviously, you're waiting for the wounds to heal up.
Yeah, that's right.
It certainly has.
And they're tighter laterally. That's what you're trying to do, right?
Yeah.
So you're trying to achieve that. I'm trying to make them more sore and tight laterally.
Yeah.
So in many ways, I'm glad to
slows them down nicely. Doesn't
Well,
it?
I think part of it is slowing people down.
Yeah.
Right. Part of it is slowing people down, and there must be a really good reason why young people rupture their ligaments more, their reconstructions more.
Yeah.
And part of it is that they're desperate to get back to it. Right?
Yeah. Brilliant. Well, I found that really interesting, Luke. So if somebody is sitting at home thinking about surgery, I think that's given them an awful lot of information to think about. And at the end of the day, if you are sitting at home without an ACL, you need to get this information, because at the end of the day, they need to make the decision as to what they're going to do, because it's their knee.
Yeah, that's right. And I think one of the things you should do under those circumstances is talk about it with your therapist, your physical therapist, talk about it with your friends, right?
Yeah.
And then go to speak to somebody who can give you all the choices, because the honest answer is, if you're a hammer, then everything looks like a nail, right? So you want to go and see somebody who can offer you all the choices of graft, have a sensible discussion with you about it, and go to see a physiotherapist that has rehabilitated all those patients.
And also be very cautious about what you read on the internet, because hopefully this gives people a fair appraisal of the information that we have. But you can easily go onto a blog or whatever, or go onto Arthrex's website, and everything looks hunky dory. But it's got to be the right decision for that individual at the right stage of their athletic career, to make sure they get the best outcomes.
That's right. And you and I have discussed this earlier on, but if there's 3,500 papers a year published on the ACL, you'll be able to find one that supports your position. I can find one that supports mine, right? Whatever we want to discuss. So I think that what you want to do is to have a sensible chat with somebody who's seen loads of these cases, because if it's your own knee, then the number of people that you know about is one, whereas you've rehabilitated hundreds of ACLs over the last 25 years, and that just gives you that greater overview of what might be right, particularly in the long term, right?
Yeah.
So whilst everybody's desperate to get back to play this year, what's it going to be like in 3 years, 4 years, 5 years, right?
Yeah,
and these are different considerations that maybe when you're in your early 20s, you haven't quite got on your radar.
So Luke, thank you very much for joining us. That was a really interesting talk.
Thanks
and I look forward to doing another podcast with you soon.
Thank you very much.